We're live on the floor of RSNA, and yes, it's true. We do have Susie Bash, the Queen of Quant, to talk to us today about what is going on in this really vital space. A lot of changes over the last couple of years, a lot of exciting information, and I'm really quite enthusiastic about the opportunity that we have today to talk. Welcome.
Thank you.
Has anyone ever called you the Queen of Quant before?
No one has ever called me that.
No one will ever stop from now on. So really, the most important thing for me is we've learned a lot about what's going on in Alzheimer's disease and how the diagnosis is made. Whereas when you first taught me about quantitative imaging, it was about looking for characteristic phenotypic patterns of volume loss. But now we know that diagnosis is based on biomarkers, and we also know that early treatment is critical, that by the time you see the volumetric changes in atrophy, it's probably too late. So is there still a role for volumetric brain assessment in either identification or treatment of these dementias?
Yeah, so really quantitative volumetric imaging has shifted into a new role in the era of anti-amyloid therapy. And that's because one of the biomarkers is neurodegeneration. And you can directly assess neurodegeneration with quantitative MRI as well as with FDG PET. And so that's what we're using it for. What we come to realize through the Clarity AD sub-study analysis is that if you can start a patient on treatment at the very earliest stage of disease, really stage 3 and stage 4. You want to catch them at the beginning of that window. And so we're using quantitative MRI to help stage disease. It's not used to diagnose the disease, that we would use amyloid PET for. But to stage disease, it's becoming very, very important. So if a patient has a positive amyloid PET and they have Alzheimer's disease, what ideally we'd like to see is preserved brain volumes on quantitative MRI, because then we can go back to the patient and say, you know, unfortunately you have Alzheimer's disease, but the good news is your brain volumes are preserved, and we know from the trial data that you'll likely do better on medication.
Okay. I know you have a lot more to tell me here, but just to keep you delving into this area, is the stage of disease used in terms of patient selection or just in terms of prognosis?
Well, I do think that it is used in terms of patient selection as well, because you need to be at the mild cognitive impairment due to Alzheimer's disease or early Alzheimer's dementia to even qualify for these anti-amyloid therapies. So you have to have some sense of the stage of disease to know whether or not you're eligible. And unfortunately, over 50% of patients are diagnosed too late and they're outside of the therapeutic window. So our role as neuroradiologists is to help establish that diagnosis early so that they have the best outcome.
As you know, you and I are both in the leadership group of the folks in neuroradiology that are focusing on moving things forward in evaluating patients with dementia, particularly Alzheimer's disease. In that role, we have all recommended that a 3DT1 be done at every visit. Are there any insights that we are getting now that we're in about 18 or so months in from looking at the volumes over time?
Well, I'm not sure that there's been a study done on everyone that's started therapy over the past 2 years. I think it would be a very interesting study to do, but there's no question that our referring physicians are finding it useful. Our volumes of quantitative MRI have gone up significantly. In fact, over the last year, they're up 206%. So we did over 24,000 quantitative MRI studies last year at RadNet, where I work. And so our referrers really are using it to help stage disease, to assess that level of neurodegeneration.
So if I'm not doing 24,000 in my practice, I'm in big trouble. Is that what you're saying? I would like to get just a little more into that. My understanding is, and by the way, don't be shy about contradicting me on camera, is that when you remove the amyloid, that brain volumes tend to shrink a bit. Is that not true?
Well, there has been some indication that initially it does. My personal feeling on this, and I don't think anyone really knows for sure why that is, but I suspect it's because you're actually removing the amyloid plaque from the brain. So you're taking a volume of disease burden and you remove it from the brain. We know these anti-amyloid therapies do a very good job of removing the beta amyloid plaque. I do suspect that there is a volume associated with that plaque, and that's why we see a little bit of a drop in volume after the beta amyloid plaque is cleared.
You know, it's hard for me to conceive that it's the amyloid volume, but you know, that may very well be true. I'm not any smarter than you are about this, so it's a difficult thing. So I didn't really want to take this interview to talk about dementia that much, but that was a issue weighing on me. But I would like to know, outside of dementia, outside of, detecting complications associated with therapy, what would you say in 2025, 26 is the primary use of volumetric imaging in neuroradiology?
Well, we
Or
still,
uses, if you like.
sure. We still get the majority of our request is for dementia indication. So that by far makes up the largest. But if you ask our referring neurologists what they depend on it the most for, most of them will say multiple sclerosis, because there are a lot of great disease modifying therapies out there for MS. And what they really want to know is what the change in volume of plaque is in the brain on when the patient comes back for their annual exams. And if it has increased a lot, if there's a lot of active disease, newer enlarging plaques, they absolutely will change the medication. So that's what they rely on very heavily. In fact, I don't have any patients that I read in my clinical practice from at least my referral base that don't order a quantitative study on every MR follow-up for MS.
But I don't understand. I can see if a patient has additional plaque. I can tell if these lesions got bigger or smaller. I'm a neuroradiologist. Is that not true?
I think that that is not entirely true. I think that that's the human feeling that we can always do it, but the truth is, and I think that it is true if you have a very small or mild plaque burden. But once you get up into moderately severe or severe plaque burden, it is very difficult to see if a plaque is enlarged or new due to differences in slice sampling and head angulation. I can just tell you, for me, when I read it, several times I think, oh, that plaque is larger, and then I look at another plane and I see it's actually the same size because we slice through it differently.
Yeah, I wouldn't have that trouble.
So the bottom line is, computers are better at pattern recognition. Humans are better at global reasoning, but synergistically, we work really well together. And so I think that AI is doing a fantastic job of actually tracking dynamic change.
Now I'm confused. You gave me all kinds of complicated concepts. I want to get back to the MS plaque. To me, the challenge in MS plaque is not the slice position so much, even though that makes sense. It is, once you get a decent burden, it's impossible. Even if they were perfectly registered, it would take forever to do the job right. I used to say, I know I can't do this, but I assume you can. But I think right now the evidence says that we really can't. We really do need these tools, right? Okay, that's a good one. Multiple sclerosis, I see that. And as you said, your clinicians, once they start, they don't go back.
They never go back.
Is there anything else in neuro that these quantifiable measurements, by the way, I would also think that the greatest impact is beyond the initial detection, again, is in the longitudinal surveillance, which I think is very important.
Correct.
Yeah, so speaking of longitudinal surveillance, and another challenge, I know one of your favorite subjects is, the way we measure masses, right? Can you tell me a little bit about how quantitative tools essentially elevate our ability to deliver value in this case?
Yeah, absolutely. The bottom line is we are relatively inaccurate at measuring masses over time. And that's why we always have to remeasure on the prior study rather than trust the measurement from our colleague on the prior study. Just the way you drop the caliper, measuring in 3 dimensions, is just not as accurate as measuring a tumor volumetrically. And so in my personal opinion, in the future, all tumors, regardless of whether they're in the brain or anywhere else in the body, will be measured and tracked on a volumetric basis longitudinally over time. I just think it's a much more accurate way of doing it. And now, fortunately, we do have FDA clearance of some tools that can do this for GBMs, glioblastoma multiforme, for metastases, and for meningioma. And metastases is not just the increase in accuracy, which is the most important thing, but it's also that these studies will blow up our day. I mean, trying to measure all of these different metastases, seeing which might be a little larger or smaller, takes a tremendous amount of time. And in general, we're probably not that great at doing it, but again, a very easy task for the AI algorithm.
Well, I always remeasure the other lesion because I assume I'm much better radiologist than the person who read before. Honestly, we've all had those circumstances where you say it's the same, but your measurements are different, and you get a nasty phone call on the phone. I have a slightly different perspective on this. I actually see from walking the floor that the ability to measure a lesion almost without any clicks is a core capability of virtually every product I see. But I do think that there are more insights to be made once you get into primary brain tumors, as well as counting lesions, which I wouldn't characterize as a routine capability. Which one do you want to talk about first in terms of its biggest impact?
Well, I do want to, before we get into that, I also want to mention tumors grow in unusual planes many times. And how do you measure a tumor if it's growing in multiple directions? And I just think that volumetrics really lends itself much better for in measuring accurately.
I couldn't agree more. I was involved with a legal case where the radiologist and the neurosurgeon were looking at the lesions on the routine 2D images. They said no change, no change, no change. When I was asked to get involved, it was clear it was about a 10% change in every individual plane. Okay, very hard to perceive, but substantial. I'm not a mathematician, but I think we had roughly a 30% volume change because of that, because of those minor changes. So I think I cut you off. You were about to say something. Tell me a little bit more about, beyond the measurement, about characterizing these tumors. Okay, because I used to do a lot of neuro-oncology, a lot of follow-up. Clinicians tend to ignore our reports because they don't really care about all the enhancement, all of this, all of that. They need more insights. Can you tell me how quantitative imaging and any other skills you have as a neuroradiologist can give greater insights and greater value to the patients who are under treatment?
Yeah, so the one thing that's important to note is that these kind of tools don't just detect the amount of enhancing tissue. They also detect the surrounding zone of flare hyperintensity. So therefore it can be used for low-grade gliomas as well. I mentioned GBMs, but also extremely useful for low-grade glioma. And again, using this, it will then give you a report, a whole lesion size, and will even measure for you the central necrotic portion of the tumor if that does exist. So I think all of these things come together to help give us insights. And the truth is it is very hard, almost impossible, essentially, sometimes to detect radiation change or treatment-related change from recurrent disease. So anything that we can do to make our tracking of these tumors more precision-based with automation, I think is very helpful.
It's an interesting thing because this is an area where I've spent a lot of emphasis in my career, and there are a lot of advanced imaging techniques that we put to bear on patients to differentiate treatment-related changes from tumor progression, right?
Correct.
And it can be very, very confusing. It has to go beyond the anatomy, regardless of how you measure it. Are there any advanced techniques, say beyond perfusion or perhaps spectroscopy, that you would advocate for doing a better, more detailed characterization of that critical question?
So one of the tools that's being used is restricted spectrum imaging, or RSI, which is an advanced diffusion weighted technology. And in some of the cases I've seen, it's really quite useful. It basically becomes the light bulb hot if it's true a tumor, which will then match your perfusion imaging. And if it's just pseudo-progression, post-treatment change, it'll be negative on RSI and negative on perfusion. So it's an additional tool that we can use in addition.
All right, so we've talked about a lot of things. You've talked about how potentially impactful quantitative assessment can be, and that I think for us to continue to thrive as neuroradiology and radiology, we have to continue to deliver value, right? But in the real world, there are things that stand in the way of the utilization of these tools. What is happening in the industry, in our field, that is breaking down the barriers to using these tools?
Well, I think it's probably twofold. One, I've seen an industry shift, which related to increased educational efforts. People are now aware of these tools, recognizing the value of these tools. And not only that, but product portfolios have expanded to the point that people now realize they can be very useful. Like some of the tools we didn't talk about, for example, automated detection of hemorrhage, can be applied for multiple different scenarios. Baseline analysis for Alzheimer's, ARIA surveillance, traumatic brain injury, and to assess vascular disease. So again, I think it's the expanded portfolio, clinical use cases, but it's also the reimbursement component. Because even if you think an AI tool has a lot of value, if you feel that it's not going to be a positive ROI for your imaging enterprise, you may not want to adopt it. Someone has to bear that cost burden. But fortunately now there are dedicated CPT codes, they are tracking codes, but in our internal audits at RadNet, we are finding a positive return on investment. And so the payers are paying at a variable rate, and then right now more so in the West Coast than on the East Coast, but on both coasts it is still reimbursement is coming in, and so that's a very positive thing.
All right, so we talked about reimbursement. We talk about a potential contribution to care. Um, isn't there an educational need as well?
Yes, and that's what I was just talking about. I think that that is really driving a big portion of the industry shift towards acceptance of these quantitative tools. But I do think that
That being education?
education about what is available and what's out. So, in other words, 10 years ago, a lot of people may not have even realized, but now that there's an expanded
Let me just
portfolio.
interrupt you because that wasn't the question I was asking. What I'm saying is the tools are there. We're aware of these tools, but maybe we don't know how to use them or how to interpret them.
I see what you're
Can
saying.
you help me as a formidable, widely esteemed, highly esteemed educator? What would you tell people about how you will learn to use these in the best possible fashion?
Yes, well, I do agree that I see where you're coming from now from an educational perspective.
I'm doing my best here.
So I can give you like a personal example. So at RadNet, we have over 100 neuroradiologists. So what we tend to do is webinars. So every couple of years, I'll do a webinar on quantitative MRIs. We have new hires each year. So, and they'll get, our neuroradiologists will get a little CME credit for it, and they can learn about the clinical applications and how they maybe sample of how they incorporate that in their report so that they can feel comfortable with the technology.
That's great. I'm really less interested in how you deliver it as to what needs to be delivered. You know, can I walk in and start doing volumetric brain imaging? Do I need to know anything special about pitfalls in multiple sclerosis? Do I need to know what to look for in some of these disease states? Or will it all be put in front of me in a canned report already in my packs? Do I have to bring any wisdom to the table, or can I just adopt this tomorrow?
Well, ultimately, as neuroradiologists, we are responsible for anything that goes into our report. So, you know, you should know to check the accuracy of the segmentation. Very good now that we use deep learning for segmentation. And I do think that you need to be aware of what you're using it for, as opposed, you can automatically pre-populate it into your PowerScribe or dictation system, which will summarize the report. But I still think there has to be fundamental education of the radiologist about what the clinical application is and how the tool is being used.
Okay, I don't know how much time we have left. I have two questions. I'm gonna let you choose which one you want to answer. Okay. You can either tell me what you're most excited about the future developments in this space, or you can tell me about the current crisis we have right now in terms of education and understanding our role in the surveillance of the complications associated with anti-amyloid therapy. You get to pick one, and you've got 2 minutes.
Well, I think that they're both important questions.
I understand that they're going to all be disappointed if you only answer one, if you only get one.
Okay, let's talk about ARIA surveillance. So these tools can measure, white matter changes in the brain. And so with ARIA, you can get edema or sulcal effusions. So these type of tools can measure that, and that can be very useful because we as neuroradiologists are responsible for grading. Again, it's just an AI assist tool, but it can be a very useful tool. And similarly, detecting blood products in the brain, counting them, and comparing to the prior study can be used for the imaging assessment of ARIA.
Just hang on. Okay, so you stopped for me. I mean, did the neuroradiologist? I just feel that neuroradiology is not entirely tuned in on our critical role in these cases. I mean, do they have to count black dots? Do they need to measure these lesions? What have we learned over the last year? Are we doing a good job? Could we do a better job? Tell me about that.
I definitely feel that we can be doing a better job. And in my personal experience, the main issue is that people some neuroradiologists or radiologists are just not familiar or comfortable with ARIA surveillance reading. So like at RadNet, we do formal ARIA surveillance training for all of our neuroradiologists. And really, if you haven't had the training, you really shouldn't be reading these studies. There are instances where, these patients are on treatment and they come in for their ARIA surveillance exam, and maybe the radiologist doesn't even mention ARIA. They don't mention ARIA because they probably haven't been trained yet in what ARIA is and what needs to go into the report. Every single ARIA surveillance report must mention yes or no ARIA. It is present or it's not present. If you're going to call it present, you have to grade it based on imaging criteria. And in my opinion, always call the referring neurologist, because they're the gateway prior to the infusion center. And the worst thing that you would want to do is not to mention that ARIA is present, and then the patient goes and gets infused on top of that and continues treatment. So again, neuroradiologists are playing a very, very critical role in safety monitoring in this anti-amyloid, therapy era right now. And so we have to do a good job here.
We have very little time left, and I'm going to ask you a yes or no question. No answer other than yes or no will be accepted. Bearing in mind what we know, how difficult this diagnosis is to make, how critical it is for the success of therapy in these patients and the risks of therapy in these patients, should every radiologist be using an artificial intelligence fueled diagnostic assistive tool when we read ARIA cases? Only one of two answers.
I would say yes.
Okay, that was more than one word, but I would agree. Dr. Bash, what a wonderful treat it is to have the opportunity to interview you, put you on the spot with zero preparation for the questions I was going to ask you. I was confident you'd handle it well, and you did. Thank you very much. Thank you to all of you, and I hope you enjoy this program.